shore on location in Chicago with thousands of cardiologists and heart experts from around the world. One of the issues they're discussing is severe heart failure, when the heart just does not pump efficiently. Usually these patients are candidates for heart transplant, but as you know, there's a severe shortage of donor heart organs. So what to do? Well, over the last several years, they've used a device to help called a left ventricular assist device, or an LVAD, sometimes called a VAD. These devices have become more sophisticated, more powerful, and smaller. We heard about the details from a specialist from Penn Medicine. Dr. Rame, at this meeting, one of the things discussed is newer, better devices to help people who have heart failure, either if they're waiting for a transplant or maybe to help them recover and have that device for a long time, or just help them have the device for a short time and then go on with their life. Tell us where we are with so-called ventricular assist devices.
Andrew, I think what this meeting is giving us more confidence to do, first of all, is to support patients on a ventricular assist device longer with a good outcome. The field has come a long way in supporting patients short-term in the hospital, where they needed to survive with a VAD, now to thinking about this as a therapy where they can be enhanced in terms of their quality of life long-term. And these are patients obviously with end-stage heart failure coming to a decision of either transplant, sometimes hospice. If there's no hope for transplant, hospice is often talked about with these patients. What the ventricular assist device therapy is giving us is a hope that the patients may be sustained for a while, at least more than a year, maybe 2 years, and have success with that strategy of putting someone on a assist device when they have end-stage heart failure due to LV due to a left heart problem. What this meeting gave us more confidence is that it's not just about one device, but maybe a second device is now coming as a possible way to sustain patients long term.
As a therapy?
As a therapy. So we have medicines for heart failure, which by the way continue when someone's on a ventricular assist device. But the ventricular assist device clearly modifies the natural history of heart failure. The end-stage heart failure patient survives longer with a ventricular assist device, and the quality of life is better. And what we are learning from now is who are the patients who are going to have the least complications from a surgical therapy like a VAD, a ventricular assist device. So that patient selection is now gearing towards let's not just make someone live longer, but have fewer rehospitalization, fewer complications from the device or from just the interface between the patient and the device. And that's sort of where the field is in terms of optimizing patient selection and therapy on the device. You asked me about recovery.
Bridge to recovery.
And I think if you want to think of it, right now we have a primary strategy of either bridge to transplant or destination. The bridge to recovery allows us for a subset of patients, and we're thinking about the younger population here who may not have, over the course of their life, an equivalent survival with only one transplant. We're thinking about a younger population that could have an improvement in their heart muscle function sufficient to explant or take out the VAD after, say, a resting period. The VAD helps the heart rest. And while the heart rests, the body gets better. Think of it like that. That's what the VAD is.
I think of it like a splint. You broke your arm or you broke your leg, and there's something supporting that limb.
I think that's a good way to look at it. The only difference is you're going to have possibly a recurrent lesion in the future. We don't know if these people that recover to the point of having their LVAD taken out may need in the future to have another surgical therapy for heart failure, either transplant or another implant of another VAD. That's an open question right now, but we do know is there's hope for, in the current era, there's hope for recovery in a subset of patients that we are trying to define. The recovery could be very durable, more than 5 years, and we are currently working together along with other centers. We're working together at Penn along with other centers at trying to come up with a study protocol for recovery that will allow all of us to collect information so that we can make some collective sense of the data at the end.
Let's go over this, because people with end-stage heart failure often feel there's not a lot of hope. There's a shortage of organs for heart transplant. They're waiting. So you've had the ventricular assist devices to help buy them time and hopefully even get them a little healthier to withstand a transplant as well. So that was bridge to transplant. We had the destination therapy where they just stayed on it, and hopefully that extended their life if a transplant wasn't available or they weren't a candidate. And now you're talking about using it with medicines therapeutically to let their heart rest, and the one day where maybe they don't need a device for some extended time.
Right. That's the concept of myocardial recovery with mechanical support.
And that's all new.
And it's new in terms of our willingness currently to push the envelope and study it more.
And feel confident.
The pioneers in this came from England, Germany. They've been looking at patients to go ahead and explant the left ventricular assist device. Dr. Bud Frazier at Texas Heart has been doing this for years as well. In an individualized manner, these centers were trying to identify, oh, whose heart is so much better that we can explant the LVAD successfully with minimal risk, and then have the patient do well long term. That's the key. It's the durability that is the key here, because most patients would argue that if they're going to have multiple surgeries, they may as well just go to the path of least resistance and come to transplant earlier. But we believe that recovery can be thought about as a bridge to decision. In other words, is the patient going to go on to improve the heart muscle function enough so that we can consider taking out the LVAD, so no transplant? And if they're not showing signals of that improvement early on, or even at midpoint, we'd call that midpoint maybe around 6 months, 9 months, well, maybe they are destined for a transplant. And that's why it's sort of a decision to be made. The good news is, if we select patients adequately, so if they have, for example, non-ischemic heart failure, they don't have heart failure due to scar, but what's called idiopathic heart failure or cardiomyopathy. If they're younger, and if they've had heart failure less in cumulative time, maybe those patients would be an enriched sample to try recovery on. Some of us believe, and I'm a believer in this, that we don't have the right patient population yet to hone in on just a sample of a subset of patients that are young with recent heart failure and non-ischemic cardiomyopathy. For that reason, we're trying to study which population of patients we're going to have in these trials. But as a clinical standard of care currently, several centers are performing LVAD turndowns. Let me explain that concept. We have the patient actually on an LVAD with the rates, with the revolutions per minute, because it's a continuous flow pump, set at, let's say, 10,000. They're doing well. Their heart's getting better. We would turn the LVAD down in the lab, in the cath lab, or in the exercise room to a support on the LVAD that is minimum. In other words, they're doing all the workload. Their heart's doing the majority of the workload to keep them alive at that time.
It's like
it's a stress test.
It's a personal training for a recovering heart.
You got it. So you're so-called weaning the VAD, but you're actually turning down the LVAD to a point at which the patient is really sustained with their own heart. If that proves right, and if the heart still looks good, and if the exercise parameters we look for are good enough, we start thinking about that patient as a candidate for recovery to explant, to getting that LVAD out. That's where the field is at right now. And some programs are doing this. We're doing this at Penn with some patients. At the University of Pennsylvania, we have several patients that we have targeted recovery because they're young. They may not have the best chance to do well with transplant. So this could be their best chance. And also what that does is it allows that heart that would otherwise go potentially to them to go to somebody else who's non-recoverable. That's a societal issue which is very important, like you said, because the organs are limited.
Right, that is so cool though. Now you're talking about seriously ill heart patients though, where you can make care more personalized.
Right.
And that is real progress. Thank you so much for that.
You're welcome, Andrew.
The combination of new and better medicines and sophisticated technology are offering new hope to people with failing hearts. In Chicago, I'm Andrew Shore.